Good morning, ladies and gentlemen. The topic of today is lymphatic system, and we start with a general introduction. What you can see is an overview of the all lymphoid organ which we have. You can see that they are spread over all the whole body, and they comprise lymph vessels and lymph organs. Why we have the lymphatic system? The lymphatic system contains a fluid which is called lymph, and this fluid is similar to plasma concerning its composition, but the main difference is that there are no red blood cells, and as for the plasma composition, there is low protein contents. The lymph is a fluid which is taken from the tissues from a superfluous fluid which is produced there. We have a special kind of lymph which is called chylus, and it's the lymph from intestine. We call it specially due to another composition which is formed by chylomicrons, a special kind of lipids which are formed in the intestine, and then they are moved directly into blood circulation, so they bypass the liver. As you can see on this scheme, the blood circulation which you can see is a closed circulation from the heart via arteries and capillary system, and then back by veins into the heart. But lymph is not such a system. It starts blindly as a cul-de-sac in tissues, and then it gathers and finally drains into the terminal portions of the venous system. Specifically into venous angle at the junction of subclavian vein and internal jugular vein. And the second difference is that there are interposed lymph nodes on the way of the lymphatic vessels. We can find the lymph vessels in all tissues and systems in the body, with some exceptions. Which are these exceptions? These exceptions are the exceptions where we have no blood vessels as well, like cartilage or cornea of the eyeball, bone marrow, and then in some where we have vessels like in placenta, and then in some organs where we have vessels, but there is another fluid which can manage the drainage of superfluous fluid from tissues, which is the inside of the eyeball, the whole inner ear where we have perilymph and endolymph. In the eyeball we have the aqueous humor, and the brain where we have cerebrospinal fluid. Yeah? Of course, in meninges of the brain, we have the lymph vessels, but not inside the tissue itself. So what is the overall function of the lymph system? So first, it's a blood filtration and purification of the filtrate via the lymph nodes. So if we have some foreign particles like viruses, bacteria, protozoa, or even tumor cells, it's filtrated in lymph nodes, and the lymph nodes then fight against them and try to get rid of them. The second function is to take an superfluous extravascular fluid into blood circulation. Then another function, which is the function of the lymphatic organs mainly, is the maturation and multiplication of the lymphocytes. Then back to lymph vessels, the function is transport of some particles, mainly proteins and other large particles, and from intestine, as I said, chylomicrons, which bypass bypass liver, and are transported directly into the systemic circulation. In one day, the production is about 60 milliliters per kilogram of the body weight. So the vessels form a system from blind capillaries into the terminal part of the venous circulation. So they start blindly. So the fluid flows from the surrounding tissue, from the extravascular fluid into the lumen of the capillary, and then it's transported farther. As it can take viruses, bacteria, protozoa, or tumor cells, there are large spaces, pores, which allows these larger particles to get in. So there is in capillaries no basal lamina. There are, of course, then valves, usually bicuspid valves, as in veins, which assures one-way flow. The lymph capillaries are parallel to small venules, and then they collect into larger lymphatic vessels. So here in this scheme, we can see how they start blindly in the tissue just surrounding the blood capillaries. A special arrangement we can find in intestine, in villi, where we have in the center of villus, we have one lymphatic capillary, which is sometimes called lacteal, as the chylus, the lymph from intestine, is whiter, and it can remind of milk. And as I said, the main function is to absorb lipids and forms chylomicrons. And we can see it here on the histological section. The number 4 shows us this empty space, which is the lymph capillary within one villus. As for the larger lymph vessels, they are thin-walled vessels, and the wall is even thinner than the wall of veins. As I said, there is no basal lamina in lymph capillaries. There is non-continuous interrupted basal lamina in lymph vessels. There are pores in lymphatic capillaries, but there are no pores in lymph vessels. So endothelium is without pores, but also without tight junctions, zonula occludentes. It's fixed to the surrounding tissue by anchoring filaments, and these filaments allows larger openings between cells during swelling of the tissue, and allows then the superfluous fluid to get into these vessels and being transported. We have quite large number of these vessels, and they contain lymph, they contain valves, as I said, and they contain lymph nodes. As for the largest lymph vessels, we call them lymph trunks, and they have quite thick middle muscular layer, which is called tunica media, with quite thin outer layer, tunica externa or tunica adventitia. So here again, the general arrangement, as you can see, the lymph capillaries start blindly in between blood capillaries, and then they collect and they enter the lymph node, and they possess these bicuspid valves. Here you can see pores in lymph capillary, and the anchoring ligament, which then allows forming larger openings during swelling of the tissue. On histological section, if you see lymph capillary and a blood capillary, a small venule, and here a small lymphatic vessel. What is the difference? You cannot distinguish these two vessels. The only sign is that in a blood vessel we have red blood cells, as you can see here. But if you would like to distinguish their wall, you need to use the immunohistochemistry. Classical histology does not allow this. Here you can see in larger lymph vessel a nice bicuspid valve. So what is the general arrangement of the lymph vessels? We start from the lymph capillaries, then we get into the larger one, which are called collectors in lymphs. Yeah. And generally we have two layers of them. We have a superficial and deep. As for lymphs, the superficial, they follow superficial veins. The deep follow the deep veins. The same is valid for organs. We have superficial and deep ones. The superficial are usually located underneath the capsule, so we call them subcapsular ones. And then we have the deep ones, which are found inside the parenchyma. Yeah? Then these collectors and these vessels from organs, they merge into lymph trunks, and these lymph trunks finally drain into lymph ducts, and we have two lymph ducts. As for the development, they are paired, but then as we have the left-sided aorta, we have also the left-sided main lymph duct, which is called thoracic duct. And you can see that the thoracic duct drain both lower limbs, and then of course the whole pelvis. Then it drains abdomen, the whole abdomen, and then it drains upper limb, half of the head, and thorax. So what is the border? The border is diaphragm and then the midline. On the contrary, on the right side, the head, the right upper limb, and the right part of thorax is drained into right lymphatic duct, which is very short one. So this is general arrangement. We are going to talk about these ducts in detail further. So as I said, we have the right lymphatic duct and a thoracic duct. The right lymphatic duct is usually like 1 to 2 centimeters long, and it usually originates from 3 trunks, as you can see, from the head, from upper limb, and from thorax. So this is the right lymphatic duct. On the left side, we have thoracic duct, and the thoracic duct originates between the crura of diaphragm. So it has very short abdominal part. Then it runs in between esophagus and thoracic aorta, so it has a long thoracic part and a very short cervical part. And it drains into, as I said, venous angle, which means venous angle is a junction of internal jugular vein and subclavian vein. So it drains directly there, and it forms an arch. So you can see then an arch. I'll show you in a figure then later. So here you can see 3 parts: abdominal, thoracic, and cervical. The cervical part forms an arch. Yeah. So these are 2 main ducts, and they receive some trunks. So here we can see the parts of the thoracic duct. The abdominal part here, which is quite short, and at the beginning we have something which is called cisterna chyli. Yeah, cisterna chyli. cisterna Kachlík or Packett's cistern is present in half of the population. It's enlargement, and there is no known function of this cistern. It is just there, and it is necessary to know about that, as you can see it on imaging methods, and you have to distinguish this from a pathological state. I will show you later. So that's at the beginning. You can hear the cisterna Kachlík and the abdominal part. Yeah. Then the thoracic duct passes through aortic hiatus together with aorta and ascends between aorta and esophagus. So it's the thoracic part. And then when it gets out in the thoracic inlet, apertura thoracis superior, we have the cervical part. And the cervical part forms such an arch behind the internal jugular vein, and then it drains into the left venous angle, so the confluence of the internal jugular vein and subclavian vein. Okay. On the other side, you have very short right thoracic duct. So this is the arrangement. And now we have some tributaries to see the main lymphatic trunks. So from the head, we have jugular trunk. From lymph, we have subclavian trunk. And then from thorax, it's different. We have so-called bronchomediastinal trunk. So these three trunks then meet and drain either here on the left side into the thoracic duct, or on the other side, these three forms the right lymphatic duct. Here at the beginning of thoracic duct, we have the cisterna Kachlík, and then cisterna Kachlík is usually the origin of the thoracic duct, and the origin of the thoracic duct comes from paired lumbar trunk. So we have right and left, so two of them, and usually 2 to 3, that means usually unpaired intestinal trunks. So they meet, and after they meet, there's in 50% an enlargement, which is called cisterna Kachlík. So this is the main arrangement and the main lymph trunks which we have in the body. What you can see here is the ultrasound of the terminal segment, that means the arch and termination of thoracic duct. So we can see here internal jugular vein, and we are on the left side where we have thoracic duct, so left internal jugular vein. Yeah. So for example, here you have the left internal jugular vein, and here drains the thoracic duct into the vein. At the end, there can be a valve. So this is normal arrangement. It can be, of course, smaller, as you can see here, the diameter, or it can be larger, as you can see here. Or it can be divided into several parts. This is really exceptional, that there can be up to 6 branches. So it's like a delta of a river. So when I come here back, maybe here, I can draw it and show you how it looks, that you have not only this one, but it can be formed like this. So it looks like a delta of a river. In Europe, for example, the Danube formed such a delta in Romania before draining into Black Sea. Why this is important? We can find here an interposed lymph nodes. Yeah? And these interposed lymph nodes we call left supraclavicular lymph nodes. Please remember that left supraclavicular lymph nodes can be interposed into the arch of the thoracic duct, and it will have a severe clinical consequences. Yeah, this information. Here are some imaging methods to show you the cisterna chyli. On the left side caudally, this is a metal injection. So this is not an imaging method, it's just a photograph of metal injection of the cisterna chyli as it originates from the right and left thoracic, right and left lumbar lymph trunk and the intestinal lymph trunks here. And you can see that it's visible also on some other structures, on some other imaging methods. You can see it here, enlarged structure in aortic hiatus, as this is diaphragm, and here aorta with calcification. So you can see such a large structure. Or you can see it if you perform lymphography, then it's nicely visible the thoracic duct, the enlargement. Or here, it's a cholangiography. So this method primarily shows the bile ducts of liver, but as the fluid, the Röntgen X-ray contrast fluid is absorbed, then it's of course absorbed by lymph, and then you can see this enlargement, which is the cisterna chyli. Yeah. So this is the reason why you should know about it and about the position. Okay. This was all the information about the lymph vessels, and now let's talk a bit about the other function, which is the immune function. So the lymphatic tissue contains many kind of cells which are derived from pluripotent hematopoietic or so-called stem cell in bone marrow. Yeah, and they are produced in bone marrow, then they travel to various organs. For example, T lymphocytes, they travel to thymus where they mature, they are educated what is proper to the body and what is foreign. B lymphocytes, they are produced mainly in nodules and so on. Then we have the other cells which are not part of the acquired immunity, but they are part of the insane immunity, like eosinophils, neutrophils, or macrophages. So what are the function of the immune cells? The main function, this is just an overview to know. So for the innate immune response, we have two cells which are able of phagocytosis. Either they are large, so we call them macrophages, and as they travel to their target tissues, they travel and they are called monocytes. When they get to their target tissue, then they are called macrophages. And then we have smaller ones, and they are called neutrophil leukocytes. On the contrary, for the acquired immunity, we have lymphocytes, T and B. We are going to talk about them a bit later. And another kind are antigen-presenting cells, which are called also dendritic, as they have many processes. So they look like dendrites of neurons, but these are of course not dendrites, they are just processes of these cells. And they also work for specific immune response. They are mainly located in epithelia, so in the skin, but also in epithelia of different organs. When they are activated, they migrate to lymph node, where they help to educate the T lymphocytes. And when the T lymphocytes are activated, then they participate in the acquired immunity reactions, in anti-infectious reactions, and in anti-cancer immunological immunity. So the lymph organs are the organs which serve us for the acquired immunity. We have primary organs in which the lymphocytes are formed, and then the secondary organs in which then during the life another maturation and then also the fight take place. So the primary organs are, of course, bone marrow, where all these cells of the lymphocytes are produced, and then some of them travel to thymus, where they are educated. In birds, we have an organ which is called bursa fabrici. That's why we have B lymphocytes. But in humans, instead of that, we have lymphoid nodules in various organs which serves for this function. So the function is to produce new cells which differentiate and mature. And then these cells populate secondary lymph organs, which are lymph nodes, tonsils, and spleen. These are the encapsulated organs. And then when they are not non-encapsulated, so they are found within other tissues, mainly below epithelium, we call them lymph nodules. In here, the lymphocytes are in contact with antigen-presenting cells. So then they react to these antigens, they multiply. So we have here a production of mature lymphocytes. So this is the way to lymph node, which is the most common encapsulated lymph organ, secondary lymph organ. So the function is, as it receives lymph vessels, it's a filtration of the lymph. Second function is when via blood come the antigen presenting cells. So they are then internalized here. So it serves for antigen presentation. The antigen presentation then causes activation and differentiation and proliferation of B and T lymphocytes. So the mature B and T lymphocytes are produced and they can start their fight. Yeah? And then, of course, we have here macrophages for destruction of particles. How the lymph nodes are spread in the human body. We have approximately 500 lymph nodes, which size is from 1 millimeter to 2 to 3 centimeters. We call them lymph nodes, and in Latin we have two terms. One is nodus lymphaticus, which is a bit older. The second is nodus lymphoidus, which is now acknowledged as the proper term. The very old term is lymphnodus. As you can see on this map, they are located along the midline, and then in some special positions, mainly in axilla and in the groin. For clinics, it's important when the lymph node is enlarged and is palpable, of course, or visible by imaging method. When it's palpable and painful, we have to think about inflammation causing this swelling. When it's palpable and painful, we have to think mainly about tumor and about catching a metastasis from a tumor. Such enlargement, palpable enlargement, is called lymphadenopathy. Yeah? So lymphadenopathy is a clinical term for enlargement of lymph nodes. So here we can see the lymph node, which is an organ. It's a small organ, but still it's an organ. It contains a cover, which is called a capsule. Yeah? Capsule from a connective tissue, which sends trabeculae inside. Inside we have a parenchyma, so it's a typical parenchymatous organ. Each parenchymatous organ, or nearly each, contains a hilum. The hilum contains vessels, blood vessels, and in case of lymph node, it also contains one efferent lymph vessel. What about the afferent lymph vessels? We can see there are more afferent lymph vessels which penetrate through the capsule in the outer convex part of the lymph node. So you can think, or you can imagine that the lymph node is like a pond or a dam, which has got more tributaries, more rivers, creeks, brooks, which take the water there. And then there's a dam and only one way out of the dam here. Yeah, so it works like that. The parenchyma is composed of three parts: cortex, medulla, and in between we have structure which is similar to cortex, but there are some differences, so it's called paracortex. So here's a nice scheme, even it's in Czech language. What is important here is to see where is cortex, which is the outermost and largest part, and you can see this circle, and this circle stands here for a lymph nodule. So a lymph node is an encapsulated lymphatic tissue, which is also composed of lymph nodules, because the nodules are the sources of the production of new lymphocytes. Then here we have paracortex, which is a structure between medulla and cortex. Yeah? Paracortex is similar to cortex, but does not contain the lymph nodules. So the histological section shows you then the structures again. This is the the connective tissue capsule. Then we have a cortex with the lymph node. Yeah. So for example, here is nicely visible a lymph node. Sometimes it's called lymph follicle. That's older name. So this is lymph nodule. So this is cortex. This is paracortex. So the part of the cortex without the lymph nodule. And then this part is called medulla, where the lymph flows. The lymph gets in, for example here, then flows here in through so-called sinuses. Yeah, the spaces are called sinuses. This is subcapsular sinus, as we see later, and it goes in between structures here or here, which we call internodular sinus. And then it gets here into the center when we have medullary sinus, and then it gets away. So this is the major structure of the lymph node. So to see it again, we have cortex, we have paracortex. The cortex contains the lymph nodules or lymph follicles. Above them, we find the subcapsular sinus. Then it flows through the internodular sinuses, then farther into medulla. Yeah? And the major component in here are B lymphocytes. When we get to paracortex, there are no lymph nodules, so no lymph nodules. The major content are T lymphocytes, both CD4 and CD8 type, and dendritic, so that means antigen presenting cells. So they come here, and how they are absorbed? They are absorbed via high endothelium in venules, which are here. So they come here via blood vessels. And these venules are called altoendothelial, where altus means high in Latin. Yeah? Maybe you know the altitude, which means the level above the sea, so the height. So the high endothelium venules are the spots where these cells are internalized. So we have talked about the cortex and paracortex. And now, when we come to medulla, you can see that medulla contains just these slips or cords, which comes from the cortex. So the medulla contains the cords, which are the processes of cortical lymph tissue. So again, it contains B lymphocytes and moreover plasmatic cells, so the cells producing antibodies. Of course, there are dendritic cells as well as in paracortex. And the sinuses in this area are called medullary sinuses, and they are lined with reticular cells, but mainly macrophages, which helps to filtrate the lymph here. As the sinuses get larger, there are reticular fibers formed by the reticular cells which cross the sinuses and forming the web, and the web then contains the macrophages. Yeah? So it's like a labyrinth. Okay, what about the arrangement of the lymph nodule? We said the lymph nodule is inside the cortex, so they are mainly the B lymphocytes, but also some dendritic cells, antigen presenting cells. So when we have the nodule contains only B lymphocytes. As I said, B lymphocytes are named after the bursa fabrici, which is present in birds only. In mammalia and in humans, we have instead the lymphoid nodules. So the lymphoid nodules in lymph nodes, they contain the small naive B lymphocytes. When these B lymphocytes meet first antigens, they start to differentiate and multiply. So something which is called germinal center develops here. Yeah? And the germinal center is usually lighter in classical histology. So they contain antigen-stimulated B lymphocytes, which start to divide. For pathology, it's important to know also the term centroblast and centrocytes, which are cells which multiply here. Yeah. So these terms you will use them later in pathology, and you can distinguish them histologically as they form a dark and or light zone of the germinal center. Of course, the nodule contains not only the B lymphocytes, but also T helpers. So T lymphocytes help maturation of B lymphocytes, and of course macrophages to remove the apoptotic cells. And at the end, at the margins, we find something which is called a mental zone. Yeah? And the mental zone is produced secondarily by moving the produced cells from the center to the side. So this process is called marginalization. And it also contains some cells like naive B lymphocytes, T helpers, the dendritic cells, follicular dendritic cells, macrophages. Yeah, that's the general structure, but we will talk more in detail about these in histology, of course. This is just to understand how it works. So to see how the lymph node really looks like, you can see quite large capsule here. The capsule, of course, contains some blood vessels. Then below that we have subcapsular sinus, and this is already the parenchyma, and that's the cortex. Yeah? So mainly the B lymphocytes. This is the section through the wall, and then when we get deeper, we can see here in cortex the germinal center, yeah, and this is the mental zone, the marginalized cells, and in the germinal center you can see darker and lighter areas, which are the centrocytes and centroblasts. When we get to medulla, you can see only these medular cords, which are processes of the cortical structures, and of course in between you can see these spaces, and these spaces are the medular sinuses, and there are the webs from reticular fibers containing macrophages. Yeah? And of course you find here blood vessels. So this is the structure of the lymph node. And now how the cells move here. So the blood vessels, they bring the naive lymphocytes from primary lymphoid organs. That means from bone marrow, the B lymphocytes, and from thymus, the T lymphocytes. On the contrary, the lymphatic vessels, the afferent ones, which are multiple, they bring lymph, and the lymph contains antigens, which has been taken from tissues, and antigen-presenting cells. They get into the subcapsular sinus, and then via the internodular sinus, they get into the medular sinus, and then if they are not internalized and used here, if they have no function, they just pass through, and they leave it via one efferent lymph vessel through the hilum. And if and moreover, there are the lymph here contains the cells which has been differentiated and matured here in the lymph node, and then continue from the lymph node back into the circulation. So here you can see an example of a cell. We have a cell which comes from, for example, bone marrow. Then it's internalized into the skin, where it forms the Langerhans cell. So this is a monocyte. This is a macrophage. Langerhans cell is its name in the skin. So it works as a or it can work as antigen-presenting cells. So when it takes the antigens, it can travel here via the afferent lymph vessels into the lymph node, and here it's internalized, and it serves as the dendritic cell in paracortex. Then here, when we have the matured cells, then gets into the medullary sinus and gets out into the systemic circulation. So this is in short about the function of the lymph nodes, but more details will be given in histology and then in immunology. Anatomy should talk about where we find the lymph nodes. So there are some general terms we have to talk about. So what is tributary region? Tributus means attacks in Latin. And here the tributary means the area from which it is gathered. So again, when we have the dam and the lymph nodes, yeah, so, or if it's a dam and it receives some tributaries, then we can call all this area a tributary region. Yeah? So this is tributary region of one lymph node. And here we have the afferent vessels, and this is the afferent vessel. Regional lymph nodes are the lymph nodes for one region. So we can have more lymph nodes here. So these lymph nodes are regional lymph nodes for this tributary region. What is a sentinel lymph node? Sentinel lymph node means when we have here in this organ a problem, it travels here and then it continues. So when there can be a tumor in this area, then the metastasis can either be stopped here or it bypasses and continues. So when we find enlarged lymph node here, we know that the problem will be in this organ. Yeah? But when there's a tumor, the tumor can bypass it. So it is not bilateral rule. The rule is sentinel, which means a guard. When we have enlarged sentinel lymph node, we know where is the problem. The typical example is Sergius lymph node. A Sergius lymph node is found on the second or third tooth or digitation of serratus anterior muscle. So you can easily palpate it here. Yeah, in axilla, you find the second or third rib, and you find the second or third digitation or tooth of the anterior serratus muscle. If you palpate there an enlarged lymph node, you know with 100% reliability that the problem is in breast, in mammary gland. But if you have problem in mammary gland, not in all cases the Sergius lymph node is enlarged. Yeah, that's why it's called sentinel lymph node, like guardian, or guard. When the guard says there's a problem, you know where is the problem. Yeah, but it does not work similarly when problem is in an organ. Not in all cases the sentinel node is enlarged. We have talked about the painful and unpainful swelling and the reasons. And what is lymphedema? Lymphedema happens when the system which I have drawn here does not work. So when this lymph node cannot drain, so when it's obturated, and it can be obturated by different reasons, like iatrogenically, by irradiation, by X-ray treatment due to cancer, or by some protozoa like filaria, which comes from water in Africa. It can then cause a stagnation of the lymph, so the lymph is not drained, and tissue in front of this blockage, in front of this lymph node is swollen, is enlarged. It's usually a limb, or it can be a scrotum, so it's enlarged. So then the limb looks as a limb of an elephant, so that's why it's called elephantiasis. And in clinics, when we have a tumor, so the stage of the tumor is classified by T and M classification. So we are going to talk about the T and M classification. So imagine we have a tumor. For example, here is a tumor in breast. So T and M classification tell us where is located the tumor, if there's an involved lymph node, so if there's a metastasis in a lymph node, and if there's a metastasis which is distant. That means it can get into lung, liver, or bone. The metastasis, that means cells from tumor which are separated and they are moved by one of three mechanisms away, and they settle somewhere and they start to produce a new tumor. So they can be moved by blood. So we have hematogenous metastasis. They can be moved by lymph. So we have lymphogenous metastasis, or they can move themselves by crawling. So they just spread directly. We call them contact metastasis. So for example, they can spread by moving on peritoneum. So this is TNM classification. How the TNM classification looks in practice. This is just to show you how it is. Please do not learn this. This is just to understand what it means. So in case you have a patient with a cancer, you examine him. For here we have the TNM classification of prostate cancer. So here you can see a small tumor inside the parenchyma. So we call it T1. The tumor is inside. When the tumor comes to the capsule, we call it T2. When it penetrates across the walls, we call it T3. And when it involves the whole lesser pelvis, we call it T4. When there are no lymph nodes involved, we call it N0. And then when we have only one regional lymph nodes, we call it N1. When we have more regional lymph nodes and larger, we call it N2. And when we have more lymph nodes and they are larger, we call it N3. And there is no metastasis, M0, and there are metastases in lungs, in liver, which is not visible here, but in a skeleton, for example, we call it M1. And based on this T and M classification, you then know what you can do with the patient. For example, T1 and 0, M0, you just remove the prostate. Yeah? In T4, you do not perform any operation, as you can see that the whole lesser pelvis is full of cancer. In case of N1, you remove them and you apply oncological therapy and radiotherapy. In N4, in N3, and it's too large, you just do not remove them and you apply only the oncological therapy. In M1, you have the metastasis. You have to think about how the metastases are severe. So based on anatomical location, you plan the oncological treatment. That's why you should understand generally what T and M means, and you should know the lymph nodes which are related to every organ. That's why we are talking about that. Now let's talk about the lymph nodes, how they are located in the human body. We start with head. Head does not contain many lymph nodes. They are located in several groups, and there are 4 main groups. We have occipital lymph nodes, which we find in the occipital region. We have lymph nodes which are in front and behind the auricle. Behind, we call them mastoid. In front, we call them parotid. Mastoid close to the mastoid process, so they are lying the attachment of the sternocleidomastoid muscle. The parotid are lying in the parotidomasseteric region on the parotid gland. And then we have a sparse group of facial lymph nodes, which we can find scattered across the face. So we call them facial. Okay? So these are 4 main groups. Of course, in clinics you can find different names. So the mastoid can be called retroauricular, The facial can be called buccal or malar, but we use these anatomical terms. As for clinics, it's quite interesting if you palpate enlarged lymph nodes dorsally, that means in the occipital region, you have to think about two important diseases, rubella. Rubella can appear in regions where there is not enough vaccination against rubella. And toxoplasmosis, which is a protozoic disease, then it's usually, its vector is cat. So majority of the people has met toxoplasmosis, but both of these are teratogenic diseases. So you have to think about that, and that's why against rubella, mainly girls has to be vaccinated, but active toxoplasmosis can also be teratogenic. So you have to think about that if you palpate these lymph nodes. Yeah, but that's clinical information. On the contrary, neck is full of lymph nodes. Yeah, there are more than 40 lymph nodes here, and we can or we have to divide them somehow. So we use the anatomical classification. We have anterior and lateral cervical region. The region is divided by sternocleidomastoid muscle. That's why we distinguish the anterior and lateral cervical lymph nodes. And then in both these areas, we have deep and superficial lymph nodes, deep and superficial. So you distinguish them into two regions and into two layers. And then we come to specific structures. Anatomically, we can describe a jugal digastric and jugal omohyoid lymph node. These lymph nodes are located at crossing of internal jugular vein and posterior belly of digastric and intermediate tendon of omohyoid muscle. So these are anatomically located lymph nodes, and in clinics they are usually not of importance, but they are anatomically described, and that's why you should you should understand where they are located. Then mainly the lateral deep cervical lymph nodes can be divided into three groups or chains. Okay, one chain is along internal jugular vein. They roughly correspond to lateral deep lymph nodes. So they are this area. Then we have a chain along trapezius muscle, its anterior margin. So along accessory nerve, it supplies this muscle. So we have these lymph nodes, which are also called accessory lymph nodes. And the third group is located here. They are supraclavicular lymph nodes. And we have mentioned already this term in relation to thoracic duct on the left side. So please, these are three groups, chain along internal jugular vein, usually called deep lateral cervical lymph nodes, accessory lymph nodes along accessory nerve, it means along the anterior margin of trapezius muscle, and supraclavicular lymph node located in omoClavicular triangle in greater supraclavicular fossa just above the clavicle. So this is the general classification of neck lymph nodes. And then we come to other smaller groups, which we already know from GIT. So we have in the anterior cervical region, we have submental and submandibular lymph nodes located in homonymous triangles. Yeah? So it won't be a problem for you. Then in the anterior cervical triangle, we have pretracheal and paratracheal lymph nodes. The pretracheal also contain a very small, this group prelaryngeal lymph node. So they are located ventrally in the so-called homotracheal or muscular triangle. So you can find them in this area. And then we have retropharyngeal lymph nodes. They are deep, so it is not easy to show here, but they are deeply somewhere here located. We can find them in retropharyngeal space, so behind the posterior wall of pharynx and in front of prevertebral lamina of cervical fascia. And they are important mainly in kids, and it was described by French anatomist and physician Rouvier. So the Rouvier's node, and you can see it on the posterior wall of oropharynx. You can see a bulging in case of severe mesotitis in kids. And so they can even be visible in oropharynx as a prominence on the posterior wall. So here you have 5 groups of anterior cervical lymph nodes. If you come to clinics and you have a tumor in the area of head and neck, you have to remove the lymph nodes. But to make it a bit easier for surgeons to remove different areas, there's a classification by Robbins, who divided this area into 6 main quadrants, and 3 of them he divided into subquadrants. And you can see that some of the quadrants they correspond to anatomical topographical sites. Here you have the submental triangle, 1B, 1A is submandibular triangle. Here this area is lateral cervical region. You can see that the omotrapezoid and omoclavicular triangle border does not match the border between 5A and 5B. Then you have the carotid triangle here in this area. So the carotid triangle then corresponds to part of 2A and 3. And here nicely we have the homotracheal or muscular triangle. So you can see that in some regions it corresponds directly to anatomical triangles, in some not. And based on these quadrants, if you have tumor in specific area, you have to dissect and remove all lymph nodes in specific quadrants. It is not necessary for you to know this. Yeah, this is for the surgeons. But you should know if you have a patient, then the patient is then aimed for removal of the organ with the tumor and so-called neck dissection of the lymph nodes, and based on the organ there are marked quadrants which has to be dissected. Yeah? So this is just for information. What you have to know are the left supraclavicular lymph nodes, which are in clinics called the nodes of Virchow, who was a famous German pathologist, and Troisier, who is quite an unknown French physician. So the nodes of Virchow, Troisier, or left supraclavicular lymph nodes are the lymph nodes which can be located within the arch of the thoracic duct. So if they are enlarged, where can be the problem? The problem, of course, can be in the neck. But the problem can be also in other organs which drain via this way. So it can be in all the organs drained by thoracic duct, as the metastasis can flow through the thoracic duct and can be caught in these lymph nodes. Most commonly, it's a tumor coming from stomach. So if you palpate in left supraclavicular region enlarged lymph node, you have to think about tumor of stomach first. It's quite far from the stomach, but this is very, very important. If not, you have to think about the tumor in the left breast. We will talk about the breast lymph drainage in a minute. You have to think about the lungs, of course. Why lungs? As we have the bronchomediastinal lymph trunk. You have to think about the large intestine, from which it is brought by the thoracic duct. Of course, you have to think about the upper limb and the head, but you have to think about the primary lymphoma, which is called Hodgkin's lymphoma in this area. So you can see that it's complicated, but it's based on anatomy as well. So now you have another information for clinics, that the left supraclavicular lymph nodes, if you palpate them, you have to think about these. If you have the right ones, in case of the right one, you have to think about, of course, tumor of the neck, the primary lymphoma, and tumor of the breast, and tumor of the lung. Not about the stomach and large intestine, as these organs are below the level of diaphragm, so they are drained only to the left side. So when it's on the right side, you just have to think only about these possibilities. If it's on the left side, you think about all of them. Well, let's talk about the organs. Tongue. How is it with the tongue? Tongue is a muscular organ, and it has an incomplete septum. So through the septum, it can cross the midline and drain into contralateral lymph nodes. From the tip, it drains down into submental. From the body, especially from margins, drains into submandibular. And from the body and the root, it drains mainly into deep cervical. So if you have a tumor here, you have to, of course, remove the tongue, but then you have to remove, of course, the corresponding lymph nodes. So in case of the tumor in the tip of the tongue, you remove the tongue and you remove all the lymph nodes, submental, submandibular, and deep cervical. On the contrary, in case of tumor here, in the root of the tongue, you remove the tongue, but you remove only the deep cervical lymph nodes. And of course, you have to think about the contralateral side. So that's the lymph drainage from the tongue. Now we continue to the trunk, to axilla. Axilla contains up to 40 lymph nodes. As you can see here on this figure, the lymph nodes are spread throughout the whole axilla. The ultrasound shows you the lymph node as a bean, and if the bean is nicely empty it is a healthy lymph node. If in the bean you can see such a hyperechogenic, that means more whitish structure, it is usually a metastatic involvement of the lymph node. How to divide them anatomically? Anatomically, we have apical lymph nodes, which are located inside or within the apex. That means medially to the shoulder joint, just towards the clavicle and skalenic fissure. Then we have the central ones. The central ones are located in the center. And then we have three groups which are located ventrally, dorsally, and laterally. Okay, ventrally, we have pectoral lymph nodes. And these pectoral lymph nodes also involve interpectoral lymph nodes. That means these which are between pectoralis major and minor. They are called Rotter's lymph nodes. Dorsally, we have subscapular lymph nodes, which drain the scapular region. And laterally, we have so-called humeral. They drain the upper limb, and they are continuous with brachial ones. Yeah, the brachial ones are located at the proximal end of the arm, and they continue as the humeral one into axilla. So this is anatomical classification of the lymph nodes. And axilla is very important for drainage of the mammary gland. So how the mammary gland is drained? Mammary gland can be divided into 4 quadrants. Yeah? And in mammary gland, we have superficial plexuses and deep plexuses. The superficial plexuses are so-called subareolar plexus, which we find here below the areola, just around. It's the pigmented skin around the nipple. And then in a peripheral area, we call it dermal plexus. Then the deep plexuses are located in the gland, so glandular plexus, and then in the fascia which covers it. The fascia which covers it is deeply is the pectoral fascia, but the whole gland is within the superficial fascia. We just got anterior and posterior lamina. The deep plexuses drain into the superficial plexuses, and the superficial plexuses drain into the axillary lymph nodes. That's why they are the most important. But the deep plexuses can also drain in other directions. Yeah? And which are the other directions which drain only 20% of the lymph node? So 80% I said is the axillary lymph nodes. Yeah? So you can see that the axillary lymph nodes, and the first node is this, which we called the pectoral node of Sorgius. As I said, it's a sentinel lymph node. That means if this is enlarged, you know in 100% that the problem is in breast. And it's located on the second or third digitation or tooth of the serratus anterior muscle. So this is the first lymph node, but of course this node can be skipped and then it drains directly into axillary lymph nodes. Yeah, and that's this 80% of lymph. But in case you have breast cancer, you have to examine breast, you have to examine axilla, you have to examine contralateral axilla across midline, especially in recurrence of the tumor, when the lymph vessels can be blocked by irradiation, iatrogenic irradiation. You have to check the contralateral side all the time. And then the other ways are to infraclavicular and supraclavicular lymph nodes. That means directly up. And then medially to parasternal lymph nodes, which are along the internal thoracic vessels. So they continue into mediastinum. We will talk about this in a minute. So you can see that the drainage of the mammillary gland is complicated. Yeah? It is drained to axillary lymph nodes, which is from the lateral side, to supraclavicular lymph nodes, which is from medial side and upper quadrant, to parasternal lymph nodes, which is from the medial side. And do not forget, it goes to contralateral axilla. Yeah? So this is the 4 directions in which the lymph can be drained from breast. Here on this transverse section of the breast, you can see the arrangement. So we start with the subareolar plexus of Sapei and the dermal plexus. Yeah, these are the superficial plexuses. Then you have the deep plexuses. So you have the glandular plexus and the fascial plexus. And these can drain either superficially or deeply. And the main drainage goes into axilla, but it can go also medially to parasternal lymph nodes, as you can see here, or can go contralaterally, that means this way, or can go up, which I do not draw in this transverse section. Yeah? So you can see that it's really a complex situation. So how to solve it clinically? If you have a problem, you perform mammography. You can see either small tumor with large lymph node or big tumor with the involved lymph nodes. Yeah? So mammography is one of the imaging methods. So if you see that here is a problem, what do? You remove the tumor. Of course, here another very, very small tumor and large involvement in axilla. So what to do? Before you remove the tumor, you perform a visualization of the sentinel lymph node. How you do it? You have 2 possibilities. Either you use a blue stain and you apply this blue stain into the tumor. You wait, and you can see how the blue stain moves into the lymph nodes. You see the colored lymph nodes, and you just remove them. Yeah, you remove the colored lymph nodes, or you can inject not a stain, but you can inject a nanocolloid which is radioactive, radio opaque. Yeah, for what we use technetium. And then after some time, you use a probe, a Geiger-Miller counter, and it shows you where is the tumor. So here you can see the probe. And then you remove them. So this is how it's applied in clinics. So in case there's a large involvement, you have to remove not only the sentinel lymph node, but also the other, which we call axillary lymphadenectomy, or if you remove all the lymph nodes which you can have, axilla exenteration. Yeah? After you perform axilla exenteration, you can meet the lymphedema. That the lymph from the upper lip cannot be drained. Yeah, so you see these. How to treat it are usually lymphomassages. So to remove all the lymph nodes, so to perform the axillary exenteration, you never remove all the lymph nodes. Why? The answer is anatomical. For the removal, we use classification according to Berg. Here you can see nicely the attachment of pectoralis minor muscle on the coracoid process. And the pectoralis minor muscle divides the axillary artery into 3 segments: the suprapectoral, retropectoral, and infrapectoral. And it also divides axilla into 3 levels. The first level is very easily accessible. The first level is located below the level of pectoralis minor. Yeah, so it contains the pectoral lymph nodes, the subscapular, and the humeral. These you can easily remove. The second level is behind the muscle, so you have to elevate the muscle, but still you can remove the central and part of the apical lymph nodes, and of course the lymph nodes between the pectoral muscles, the Rotter's interpectoral lymph nodes. But the third level, which is located above the level of the muscle here, in the apex of axilla, where is not enough space, and it's usually also located behind the artery and behind the brachial plexus fascicles. So these apical lymph nodes you are not able to remove, and you have to use radiotherapy for that. So the X-ray. So axial exenteration means you remove only the first and second level of the lymph nodes. During this removal, usually the intercostobrachial nerve is harmed, and it can cause paresthesia or anesthesia in axilla. So, and after you successfully treat the cancer, you should reconstruct the breast, and the breast can be reconstructed by musculocutaneous flap, and you can use for this flap either rectus abdominis muscle, or you can use latissimus dorsi muscle for that. And to conclude this area, we have to talk about the upper limb, and we have talked about the limbs that they contain collectors, and they contain deep and superficial lymph vessels. The deep vessels, they course along the deep blood vessels, and they are named similarly to them, and there is usually no clinics about that. As for superficial one, they approximately follow the superficial veins, but they are more in a number. So when you have one cephalic vein, there are several trunks which run approximately along the cephalic vein. So we have 3 groups of collectors, as we have 3 major veins. We have cephalic vein, so we have the lateral group of collectors. We have basilic vein, so we have medial group of collectors, and we have median antebrachial vein, so the shortest and in number the smallest group is the ventral group. Do we have any lymph nodes in the limb? Yes, we have. They are deep ones in axilla, in cubital fossa, which we call cubital lymph nodes, and the most prominent are located just above the level of trochlea, so supratrochlear, but they are in number only 2, 3, or 4, and they continue as the brachial. And we have 1 or 2 small superficial ones, yeah? And the superficial ones, they are interposed in the medial the medial collectors. Yeah? But clinically, they are not much relevant. Usually when you have problems in inflammation in fingers, the first lymph nodes which are enlarged and palpable are the axillary lymph nodes. So that's for the upper limb. And now we move to into the thorax. We are going to talk about the lungs. Lungs as an organ has again a typical arrangement, so it has a superficial and deep plexus. The superficial is located just below pleura, so we call it subpleural plexus. The deep one is located along the pulmonary veins, arteries, and bronchi, so that's the deep plexus. If we go in into the smallest unit, the wall of alveoli possesses no lymph valves. Yes. What about the drainage? The drainage is very clear. We don't know why it's arranged so, but the right lung drains on the right side. The left one drains to both sides. We have to remember that to the left side, that means to thoracic duct, drains only upper 3 segments. That means the apical, posterior, and anterior segment of the left. The rest drains to the right side. Yeah. So please remember that, and you can see it here in this figure, that upper 3 segments drain to the left, then the rest of the left lung drains to the right. Which lymph nodes serve for that? We can see the lymph nodes here. So we have lymph nodes which we call paratracheal, yeah, and they continue from thorax into the neck to anterior deep cervical lymph nodes. And then we have the lymph nodes the bifurcation of trachea. So we have tracheobronchial, and we have right superior tracheobronchial, which drains to the right side. We have inferior tracheobronchial, which drains to the right side. And we have left superior tracheobronchial, which drains to the left side. Then we have lymph nodes at the level of the hilus, which we call bronchopulmonar, and then we have those which are within the parenchyma inside the lungs, which we call intrapulmonar. So these are the names of the lymph nodes. So again, to summarize, so we start from intrapulmonar, we go to bronchopulmonar, which we find in hilum, and upper 3 left segments, they drain into left side. Yeah? The rest drains to the right side. Of course, if you have a tumor in this area, you have to remove some segments, lobes, or the whole left or right lung. And if you operate, you need to know this clinical classification, which consists of 14 groups. Yeah, but this is specialized for pulmonary surgeons. So it's more complicated than what we learn. As lungs are part of thorax, the rest of the thorax is filled with mediastinum. And we have different classification of mediastinum, but we still adhere to the anatomical one, where we classify it into the superior and inferior in posterior inferior, middle inferior with the heart in pericardium, and anterior inferior mediastinum. So then the lymph nodes can be easily called mediastinal lymph nodes. That's clinical terminology. But what about the anatomical terminology? So in the superior mediastinum, we have superior tracheobronchial, as the level between the superior and inferior mediastinum is at the level of tracheal bifurcation, so level T4. So we have superior tracheobronchial lymph nodes and paratracheal lymph nodes. In the inferior, it depends where we are located. If we are located dorsally, so the posterior inferior, so these are clinically the posterior mediastinal lymph nodes. These are lymph nodes which are located around esophagus and vertebral column. So we call them juxtaesophageal, when juxta means by or close by, and prevertebral lymph nodes. Yes, so juxtaesophageal and prevertebral lymph nodes. In the middle, inferior mediastinum, we have inferior tracheobronchial, which are below the bifurcation of trachea, and bronchopulmonal, which we find in hilli of both lungs, and some for the heart, lateral pericardiac, which are located along phrenic nerves. And finally, the anterior inferior, which are called clinically anterior mediastinal. So it contains the parasternal lymph nodes, and especially those close to mammary gland are called paramammary lymph nodes. So they are located along the internal thoracic artery. And then some smaller groups in intercostal spaces, intercostal lymph nodes, and the superior aspect of diaphragm, superior phrenic ones, and prepericardiac in front of the heart. So you can see that anatomically there are more groups located in mediastinum. Okay, when we continue below the diaphragm into abdomen, that means below the level of diaphragm, all the lymph is drained from here exclusively by thoracic duct. And the thoracic duct originates at the upper border of the abdominal cavity between a crura of diaphragm at the level of L1, and we can find here in 50% the enlargement called cisterna chyri. This we know. If we look here into the retroperitoneal space, there are many lymph nodes located in the lumbar region. So we call them lumbar lymph nodes. And how we classify the lymph nodes? So we can classify them as parietal on the wall and visceral close to the organs. So the parietal are mainly the lumbar ones, and there can be also lymph nodes located on the inferior aspect of diaphragm, inferior phrenic ones, and caudally at the inferior epigastric vessels, so close to inguinal canal, inferior epigastric lymph nodes. But these groups are very, very small. And the lumbar ones, they contain more of them, so they have to be classified into left lumbar, right, and intermediate. So the left will be located on the left side. So they are these. So they can be located in front of aorta, behind aorta, or on the side of aorta. So we have pre-aortic, retro-aortic, and lateral aortic lymph nodes. Then we have the right one. The right one has to be located close to inferior vena cava. So they are located ventrally, precaval, dorsally, retrocaval, and laterally, lateral caval lymph nodes. And of course, then we have something in the middle, in between these two vessels, which we call intermediate. Yeah, so all these, which are clinically called para-aortal lymph nodes, and they can be even removed as a whole if necessary. We can anatomically divide into left, right, and intermediate lumbar ones, and then according to position to create vessels into pre, retro, and lateral. So that's the classification of the parietal ones. And we can also see them. Here, there's a nice CT in frontal plane. So you can see some organs like kidneys, liver and spleen. And the lymph nodes are located here. So these are the lumbar lymph nodes. This is the psoas major, for example. And here the lymph nodes are visible. Yeah, these are a bit enlarged lymph nodes, but they are visible. One of the very severe diseases is tuberculosis, and especially in countries of the third world, you can still meet very active tuberculosis. And here we can see such an example of enlarged lymph node. Yeah, you can see aorta, inferior vena cava, and enlarged lymph node caused by tuberculosis. Yeah. In our countries, mainly these lymph nodes are visible in cancer. So here you can see enlarged lymph node due to colorectal tumor metastasis. So these are clinical units which are connected with these parietal lymph nodes. Now let's talk about the visceral lymph nodes, which are connected with the diseases of the specific organs. So we know that we have superior, inferior mesenteric artery and celiac trunk. So we have inferior mesenteric and superior mesenteric lymph nodes and celiac lymph nodes. The celiac lymph nodes are the most important one, which then form the intestinal trunks, which drain into cisterna chyli. And if you read the names of the lymph nodes, they correspond to the vessels and to the organs which we have in this area. Yeah, so we have gastric, gastro-omental, pyloric, pancreatico-duodenal, pancreatic, splenic, hepatic. As for superior and inferior mesenteric ones, if you read them, they also correspond to vessels and organs. So we have juxtaintestinal, ileocolic, pre- and retrocecal as the anterior and posterior cecal artery, appendicular, mesocolic, sigmoid, superior rectal. Yeah, so if you know well the blood supply of the organs, you know the name of the lymph nodes in this area. But of course, if you have a cancer, you have to operate the organ and remove the related lymph nodes. So for the stomach, there are 5 groups, but if you know the vessels, you know the lymph nodes. So we have right and left gastric, right and left gastro-omental. As we have a pyloric vein, we have also pyloric lymph nodes. There exists an incomplete lymphoid annulus of the cardia, and it is not much of clinical importance. So from these small groups, then it drains into celiac lymph nodes, and then it gets into the thoracic duct. And do not forget the left supraclavicular lymph nodes called the Virchow-Troisier lymph nodes. If they are palpable on the left side, you have to think firstly about the cancer in stomach. But if you are a surgeon and you would like to remove them, you of course know they are located here as a chains along the lesser and greater curvature. But for surgery, you have to classify them more in detail. So we classify them into 16 groups, as you can see here. And then here is one of the technique of the lymphadenectomy. So you can divide these 16 groups into 3 compartments, and then you remove these compartments. Yeah. So this is again important in clinic. So when you come to the 6th year to the surgery department, you will come to this detailed lymphadenectomy classification. When we move to liver, liver is usually site of a metastasis from colorectal cancer, but there can be also a primary tumor with involvement of the lymph nodes. And where are these lymph nodes located? They are located, of course, along the vessels, common and proper hepatic. And we have two special lymph nodes. One is close at the foramen omentale, which is the entrance to omental bursa. So it's called foraminal lymph node. The one is called cystic lymph node, which is located at the site of junction of cystic duct and common hepatic duct. So it's close to the neck of the gallbladder. So these two are specifically located. We can see them here. Here is the foraminal and cystic lymph node. As for the small and large intestine, they of course drain into celiac and lumbar lymph nodes, but they are usually arranged in 3 to 4 rows. So you can imagine you have a intestine, then you have here the big vessel which supplies that. And on the way, there are lymph nodes. So they are located in 3 rows. So you have the juxta-intestinal for the small intestine, or epicolic and paracolic for the large intestine, which we find here. Then you have the central ones, either superior or inferior mesenteric, so the central ones. And then in between you find the intermediate. So you have 3 rows. So what do you do if you have here a tumor? You perform wedge-shaped resection. So you have to remove the tumor, then a safe zone, and then the whole mesentery or mesocolon. Yeah? Usually the tumors of the small intestine are not malign, but in large intestine they are very malign, so you have to remove this. Sometimes you remove even the half of the large intestine. And do not forget that there are metastases taken by venous blood into the liver. And so you have to examine the liver, and sometimes you have to cure the metastasis in liver as well. So imagine remember that there are 3 levels of lymph nodes in the small and large intestines. So we can see the arrangement here. So we have the central groups located here. We have the epicolic and paracolic lymph nodes, which are located here. And there can be some intermediate lymph nodes in between. Here is a live specimen, so you can see nicely a lymph node, and even here the whitish fluid, which is the chylus, the lymph in the intestine. And the lymph nodes, the enlarged lymph nodes, can be visible on CTs as well, yeah, especially during colorectal carcinoma involvement. Of course, the sentinel lymph node can be used in any other organs, so it is used in a large intestine in colorectal cancer tumor as well, but then the sentinel lymph node is not defined anatomically as the Sordius lymph node in axilla, but it is defined only clinically, that you inject the fluid, in this case the blue stain, into the tumor, and when you see the involvement of the lymph nodes, you remove all of them. When we move to organs which are developed in the abdominal cavity but they descend, we have to remember that in gonads, that means testis and ovary, they took all the blood vessels, lymph vessels, and innervation from level of L2. So when they take it, they descend. So we have to know that tumors from ovary and from testis, even they are located in lesser pelvis and in scrotum respectively, the involvement is in the area of L2. So you have to remove the testis, and you have to apply radiotherapy to level of L2. Yeah. If you have a suspicion to tumor in testis, so inside scrotum, you never apply puncture. Yeah, remember, no puncture. If you perform the puncture, then you can spread the tumor via the needle into superficial inguinal lymph nodes. So then the patient is harmed iatrogenically, yeah, because he's got tumor in testis, involvement of the lumbar lymph nodes. But if you perform the puncture, you spread the tumor into superficial inguinal lymph nodes, and this is what you do not want to perform. So remember, no puncture, you just remove the whole testis away. Yeah. So we get from abdomen into pelvis. In pelvis, as in abdomen, we have parietal and visceral lymph nodes. The parietal are called according to the vessels. So it's very easy. We have here common iliac, external iliac, internal iliac, and then tributaries of the internal iliac vein. So we have superior inferior gluteal lymph nodes. Obturator lymph nodes, which are located along the obturator vessels and nerve, they usually drain not to internal but to external iliac lymph nodes, yeah, which is exception. And then we have a group which we call sacral lymph nodes. They are located at the posterior wall of the pelvis, and these sacral lymph nodes receive lymph from the organs which are located dorsally. Of course, rectum is a bit in front of the sacral bone, but from the prostate and from what corresponds to prostate in location in female, that is cervix of uterus and fornices of vagina, which encircles the cervix of uterus. Of course, we have small visceral lymph nodes. They are located next to every organ. So we have paravesical next to urinary bladder, parauterine and paravaginal next to internal female genital organs, and pararectal next to rectum. They are very small and they are removed with the organs themselves. So how to visualize them? You apply a lymphography, and when you apply the lymphography, you can see the involvement of the lymph nodes, and then you have to remove the lymph nodes. So in a large spread of the metastatic process, you have to perform both pelvic lymphadenectomy and para-aortal lymphadenectomy. And you have two approaches, classical or using laparoscopic instruments. So again, specifically to organs, and tumors of uterus are the most common in a female in this area. So we have to know that the drainage of the uterus is very, very complicated. Here you can see the uterus and vagina and ovary, and we know that from ovary it is drained to lumbar lymph nodes. Yes, so this is one way, to lumbar lymph nodes. The other way is along the vessels. So from the body, it drains into internal iliac, external iliac, and common iliac. Then dorsally, it is necessary to remember, and as I said, from cervix of uterus and the fornices of vagina, it drains into sacral one. And then, not very common, but it can happen, from margins along the round ligament, which goes through inguinal canal, it drains into superficial inguinal ones. Okay? So you have four directions. When you come back again, we have lumbar, which is mainly from ovary and the fundus, a part of the body. Iliac, internal, external, common, which is mainly from the body and part of the isthmus and cervix. Sacral, which is mainly from cervix and part of isthmus. And rarely to superficial inguinal, which is mainly from margins and cornua. Yeah. So you have to examine the whole pelvis. You have to examine the retroperitoneal area with the lumbar lines, and you have to examine the groins as well. So this is anatomy. Clinically, we know that we have two different tumors. We have tumors of old ladies after menopause. They have tumors usually in the body of the uterus. So in this case, you have tumor in the body of uterus. You go to examine the iliac lymph nodes, yeah, internal, external, common, the lumbar lymph nodes, and superficial inguinal. In case of tumor of cervix, which is a tumor of younger ladies, smokers, and the promiscuous ladies who change their partners too often, so they suffer from HPV infection, which now we are happy that there's a vaccination against that. So the involvement is of the internal, external, and common iliac, but also of the sacral one. Yeah, so two kinds of tumors, and you can see that the anatomical that the spread is anatomically different. So please remember that. As for the cervical cancer, there's a study showing the involvement of the lymph nodes. So you have to realize that this is the area of the involvement, and you can see what is most commonly involved. Most commonly involved is, of course, what we find closely, so the parauterine and paravaginal lymph nodes. But you can see that also the inguinal lymph nodes can be involved, as well as these lumbar lymph nodes, which we find here, and distant metastasis, so somewhere in lungs, liver, or skeleton. Okay, now for male, very common cancer of late age is prostate, and from prostate it is drained into internal, external, and common iliac, but as it's located also dorsally as the cervix of uterus, also the sacral one. Yeah, so as you can see here on this figure, the prostate is located below the urinary bladder, and it involves the iliac lymph nodes and the sacral lymph nodes. So when you are a surgeon in this area, this is a view of the pelvis. This is ventrally here, and here is dorsally. So you have to remove all the lymph nodes which you find between the internal and external iliac vessels. So it involves also the obturator area. Yeah, so this is the area which should be extended in, should be removed and cleaned in prostate cancer. And the organ which is often involved by tumors in both sexes is rectum, and again based on the blood supply, majority, so the ampulla, majority is drained by superior rectal vein. That means inferior mesenteric vein. So superior rectal lymph nodes and inferior mesenteric lymph nodes. On the contrary, the para-aortal area is the abral part is drained by para-rectal lymph nodes and internal iliac lymph nodes. Of course, we have to examine the sacral lymph nodes and the obturator ventrally. So finally, all iliac lymph nodes. But for anal canal, which is the most abral part, pararectal lymph nodes, but also the superficial inguinal lymph nodes, yeah, and it's located superficial at the perineal area. So that's for rectum. And finally, we are going to lower limb. What is axilla to upper limb is groin to lower limb. So we have here a group of some, we can say, up to 20 lymph nodes, which are located superficially and deeply in the area of femoral triangle, mainly iliopectineal fossa and lacuna vasorum, so the vascular space. You have superficial and deep ones. The deep ones are located in iliopectineal fossa, and the most proximal one is called Cloquet-Rosenmüller lymph node. It is quite large one, and it's located most medially within the vascular space, lacuna vasorum. Yeah? So the deeper ones are the larger ones, and the superficial ones, they are located according to the position to saphenous hiatus, so according to the position to venous subinguinal confluence. So we divide the inferior ones, we divide the supermedial and superlateral ones. They have a very large tributary area, yeah? So they, of course, take all the lower limb without the posterior side of the leg, which is drained deeply, yeah, as we will talk about this later. But then it takes also the whole gluteal region, the perineal region, the anus, the skin of penis or clitoris, the epithelium, the mucosa of vestibulum of vagina, the skin of scrotum and labia, and the whole lower ventral abdominal wall, plus cornu of uterus, and as I said, this for the organs, the anus and anal canal. Yeah, so very large area of the body. And we have here a second anatomical sentinel lymph node, which is called Cabanas lymph node. And it's a supermedial superficial inguinal lymph node, and it's a sentinel lymph node for penis skin cancer. Yeah, penis skin cancer. Cabanas lymph node supermedially located. So that should be somewhere here. Okay, so that's the groin. And we come to collectors of the lower limb, as we have again some deep ones, and they are along the deep vessels. And as we had some cubital lymph nodes, in the upper limb we have deep popliteal lymph nodes here. Yeah, usually 2 small ones. As for the superficial, they also run approximately along the superficial veins. They form 3 groups of collectors, which are quite large in number. Especially the medial group contains even 10 to 15 collectors, and they run along the saphena magna or in the vicinity of saphena magna. The lateral ones, they run along tributaries of saphena magna, that means mainly anterior accessory gray saphenous vein. And then we have the dorsal, which are shorter, they run along the small saphenous vein into superficial popliteal lymph nodes, and then they get deeply. So that's why the dorsal aspect of the leg is not drained by the superficial inguinal lymph nodes, but only by the deep inguinal lymph nodes. As the superficial lymph nodes, we have the popliteal, we have the superficial, the deep, and anatomically the most distal lymph nodes can be found at the origins of anterior and posterior tibial artery, tubular artery, but they are not clinically important. Yeah? So to conclude the area of the lymph nodes, remember that they are palpable. Some of them can be even visible how they are enlarged. And of course, if they are painful, it is usually inflammatory. If they are not painful, it is usually due to metastatic involvement. Routinely, you have to examine the neck lymph nodes, the axillary lymph nodes, and the groin lymph nodes. Yeah. And they can be enlarged in a tumor. They can be enlarged after the operation. They can be enlarged due to some infection diseases like erysipelas or protozoa filariosis, as I said. And here you can see the involvement of the lymph nodes, which then causes lymphedema, and the treatment by lymphodrainage. How to examine them is using lymphography or lymphoscintigraphy. So you can use either contrast fluid, which is instilled, as you can see here, by a syringe and needle into the first interdigital space in the lower limb, or into the upper limb if you need to examine the upper limb, and then you have to wait, and you instill either the contrast fluid or the radioactive fluid. So then you can see how the lymph vessels look normally, and here you can see some involvement of the lymph nodes. So please remember, lymphography and lymphoscintigraphy can be used to visualize the lymph nodes. So we have talked about the capsulated lymphoid tissue lymph nodes. Now let's talk about the non-capsulated lymphoid tissue. So this means lymphoid nodules located in organs. So we call them either diffuse or organized mucosa-associated lymphoid tissue. So when it is diffuse, they are just diffuse cells. So you do not see them as a clusters, but diffuse cells. This is mainly present in GIT. The organized one is organized in lymphoid nodules, and they can be either solitary or aggregated. And that's one of the difference between the jejunum and ileum. Ileum contains both solitary and aggregated, jejunum only solitary one. So in ileum, the aggregated are called agmina of Peyer. And do not forget that we find them also in a large intestine, in vermiform appendix. Yeah. The number of the lymph cells in this area is so immense that we sometimes call gut the largest immune organ, and it's because we get to largest amount of bacteria, viruses, and protozoa just via nutrition. Yeah, but not only via nutrition, also via the air which we breathe. That's why we have the lymphoid nodules in the nose and in bronchi. Yes, and then we just call these by abbreviation D mold and O mold, and in GIT G or GALT, and in respiratory system NALT or BALT. And we have this also in other organs, in skin, as I spoke about the Langerhans cells, which are located here and function as antigen presenting cells, but we have also here mastocytes and keratocytes, which participate in the immune functions. And of course, we find this non-capsulated lymphoid tissue in other organs like gallbladder, vagina, mammary gland. And what is important, conjunctiva, in allergic reactions, you can see chronic inflammations of conjunctiva. And here's an example of such O-malt You can see nice lymph nodule in ileum. Yeah, this is Lubberkin script or intestinal gland. And then in submucosa, you can see such a nicely aggregated lymphoid nodule. Then we come back to capsulated lymphoid tissues. And the first barrier which we have in GIT and respiratory system are tonsils. So this is fully or partially encapsulated lymphoid tissue under epithelium, and we have talked already about all of them, and they form such a circle. The circle is not connected, it's more a theoretical circle, and this circle consists of one lingual tonsil, which is located in the root of the tongue, two palatine tonsils, which are located in the oropharynx. It's located between anterior and posterior pharyngeal pillar, or palatoglossal and palatopharyngeal arch, so in the isthmus of Faucium. And what is important here, there's a thick capsule, and there are many crypts. Then we have one pharyngeal tonsil, which is located in the fornix of nasopharynx. And if it's enlarged in clinics, it's called adenoid vegetation. And there is very thin capsule and no crypt. And then we have two smally, the smallest one is the tubarian one. It's paired and it's located at the pharyngeal ostium of Eustachian tube. Yeah, so this is the blue one. The pharyngeal is the red one, and the lingual is the green one, and the palatine is this orange one. So these are the tonsils, and now look at them a bit more in detail. Here you can see the largest, the most important, the palatine tonsil. When it's too enlarged and inflamed, we remove it and we call it tonsillectomy. And during tonsillectomy, you have to think about the thick capsule and quite large bed. So if you remove this quite large bed, it can cause bleeding. So what is important after removal of that? No physical activity, and what is also recommended, eat some ice cream as it cools down the area and stops bleeding. The bleeding can be caused during the operation by harming of this vein, which we call external palatine vein. This vein does not possess any arterial counterpart. So please remember, we have this external palatine vein, which is closed. And just behind the constrictor here, we find large artery, and it's the internal carotid artery. So there's a danger during the operation that you can even harm this artery and cause fatal bleeding. Yeah? So remember that there are three complications of tonsillectomy: large bed of the tonsil, external palatine vein, and internal carotid artery. Here you can see on the histological slide nice lymphoid nodules with germinal centers. On the surface you find epithelium. The epithelium in oropharynx is, of course, striated, non-keratinized squamous epithelium. Here you can see a nice crypt. That means it is not fully encapsulated. It is partially encapsulated because here it's opened. And as for development, do not forget that the tonsil is developed, or its bed is developed from the second pharyngeal pouch. But of course, the lymphocytes are of mesenchyme origin as they migrate here from bone marrow and thymus. So here we can see the examination of the palatine tonsile, and you nicely see the soft palate, that means the uvula here, and the anterior pillar, that means the palatoglossal arch, and the posterior pillar here, which is the palatopharyngeal arch, and in between is the palatine tonsile. Yeah, so this is normal one, and here you can see cases with the inflammation with the white cover. Yeah, and here is very enlarged one. So pharyngeal tonsil is visible by epipharyngoscopy. Epipharyngoscopy means that you apply the mirror here and you look up and see the enlarged one, so adenoid vegetation. So you can see this is the examination of the adenoid vegetation. You can see that it's enlarged and it is reddish. Yeah? And the inflammation is also on the posterior pharyngeal wall here. So here are different stages of the involvement of the pharyngeal tonsil to be removed. Yeah, so adenoid vegetation is the clinical term for adenoid. Tubal tonsil is not enlarged so often, usually after adenotomy or tonsillectomy. So then you can see an enlarged tonsil close to torus tubarius, and it usually closes the pharyngeal ostium of Eustachian tube. And the lingual one is also not often involved in inflammation, so you can see it as these enlargements on the root of the tongue. Yeah, close to it, they are located at the mucous glands of Weber. So this is the lymph node, and below are the mucous glands. What is important for the clinics is that we have the lymphatic tissue also in the walls, in the lateral and posterior wall of oropharynx. So what you can see here again are the palatopharyngeal and palatoglossal arch, or anterior and posterior pillar. And here on the posterior wall, you can see these. So it then forms such bends. So on the sides and on the posterior wall, they are lateral and posterior bends, and they can also be enlarged. So remember that we have the lymphoid tissue not only located in the tonsils, but also in lateral and posterior wall of the pharynx as well. So, and at the end, we have here a case report. So you have a female patient who suffers from dysphagia. So you think, okay, there can be a problem in the nasal or oral cavity. So you examine and you find that there is no inflammation in nasal cavity, no inflammation in oral cavity, pharynx, neither larynx. Okay, you think, but there's a problem. I should also examine the lymph nodes. You try to palpate the lymph nodes, but there are no neck lymph nodes. So there is also no fever, no sign of inflammation, no weight loss, no sign of malign tumor. But if you look there, you see that there's an enlargement in the palatine tonsil. So in case there is a fever, there are painful lymph nodes, you would think about the tonsillitis, the inflammation, or an abscess. But this was a really rare case, as you did not know what to do. So we performed the CT and then here the angiography, and we find out, or they find out a very, very large tumor in this area. And they find out that the tumor is here supplied by branches of the carotid artery. So what was the solution? The solution was very, very rare tumor of vagus nerve. Yeah? Paraganglioma is a is a tumor of the ganglion of vagus nerve within the jugular foramen, and it caused bulging of the wall of the pharynx inside. That's why it looks as an enlarged tonsil. Yeah. So if you look at this figure, you would think, yeah, the problem is in tonsil. But if you then say, okay, there are no other symptoms of inflammation or tumor in tonsil, we have to look for structures which are located behind the tonsil. Yeah. And in this case, it was involvement of the vagus nerve. So that's why you learn anatomy, because the anatomy can help you in treatment of the patients. So thank you very much for your attention, and we will continue in the second lecture with the topic of the thymus and spleen. Have a nice day and goodbye.